Welcome everyone. My name is Danish Bhatti. I'm a movement disorders neurologist at University of Nebraska Medical Center. I am the director for Parkinson's disease program. I'm the associate director for our movement disorders fellowship, and I am curriculum director for our residents, and I direct an international neurology program. So I'm going to be reviewing today this topic very briefly of movement disorders, which is the specialty that I practice. It's a part of neurology that focuses on diseases that cause abnormal movement, either too much movement like jerking, twitching, shaking, or not enough movement such as spasm, spasticity, dystonia, slow movement, Parkinson's, and difficulty walking, balance problem, and so on and so forth. So I wanted to give you a quick snapshot of the field of movement disorder. It's really vast. There are more than 1,000 diagnoses. So it will be just a very brief introduction of what is movement disorders. Why is it important to talk about health loss due to disability is from brain disorders, and they are 8 times more common than heart diseases like coronary artery disease and 20 times more common than cancer. So in our UNMC, University of Nebraska Medical Center movement in our center. This is my team, wonderful team who I work with. This is a division of movement disorders at University of Nebraska. I would like to dedicate the talk to memory of my father who passed away in 2016, and he wanted me to do more teaching, including online teaching. So, what are we going to cover today in the next half hour or so? We will talk about what are movement disorders and the common conditions. We'll talk about the basic functional anatomy of a movement disorder, and we will discuss some very common treatments that are used for movement disorder to give you some idea. Why is it important to talk about movement disorders and what impact can we make? I wanted to show you a case that I consulted on in Pakistan during one of my visits to give you an idea of how impactful we can be. So hopefully this video will play well. So let's watch this case. This is a young worker who has works in Middle East. He's visiting back home in Pakistan. He develops these abnormal movements with shaking
इधर
and
देखें ऐसे ऐसे
jerking of
मारना
his
है आपको
arms, his trunk, his legs, pulling back of his head and neck, and is, as you can see, it's very disabling. He's
राइट
not
वाले
able
को
to
करें
work well. He has tried many therapies, did not work, and I was consulted to see if I can help
खड़े हो जाए जरा
diagnose this case and help treat it. And just the right
खड़े हो जाए
diagnosis is
साहब
so useful in making a big impact. So I made the diagnosis, recommended the treatment,
हाथ सामने
and
करें
let me show you the next video with 3 months after treatment. So this is him 3 months after treatment. Standing, walking, just like before, and you look at the amount of improvement this person has had.
जी चलो
So his diagnosis was functional
खुश
movement
जाइए
disorder, and his treatment that I recommended was cognitive behavioral therapy, CBT, for psychotherapy. How common are movement disorders? Well, this is one type of movement disorder. 3% of general population in their lifetime has a risk of developing essential tremor. 4% have a lifetime risk of developing Parkinson's disease, and another 4% have a lifetime risk of having Tourette syndrome. So if you just take these three diseases alone, that's 10% or 1 in 10 people who are at risk of developing these movement disorders in their life. So they're really common. If they're so common, then why are they not seen that often? And here is the problem that if you don't know what to look for, then your eyes cannot see what the mind movement, and you really don't know that there is something going on or what is going on. And that's why movement disorder seems so challenging. So let's look at some of these descriptions or definition. So what is a tremor? A tremor is an oscillatory movement that moves around a center point. So if you have a center point or null point and the hands move to and fro, oscillate around that null point with alternative contractions of agonist and then antagonist, then that creates a muscle. That creates a tremor, and tremor can be seen in things like essential tremor, Parkinson's tremor. Let me show you a patient video to give you an example of what a tremor looks like. So here's a case: patient raises his arm up, has this jerky movements to and
Put
fro
your
of
hands
his
straight out
hands,
in front of you if you
up and
would.
down.
Just hold them there for
And that
several
is what a
seconds.
tremor. So tremor can be at any joint, tremor can be in any direction, could be any speed, any amplitude, and so on and so forth. Another
Okay, now
abnormal
let your
movement will
wrists
be
just
chorea. So what
drop
is a
down
chorea?
and
Chorea
just
is
hold them.
basically fast, jerky, involuntary movement that flow randomly from one part of the body to the next one, so that you cannot predict.
A few minutes and just
Restless
relax.
center here, which is called basal ganglia, and this here is where all these abnormal movements are coming from. So there are different structures here that are labeled, but let me give you a more 3D representation of what we're seeing. So if I take the same slice with 3D reconstruction on an MRI, so you can see the MRI is now more horizontal slice here with the eyes on the front. This is the brainstem and the two hemispheres. And if I zoom in into this area, which is now shown here, you see these structures. This is the optic tract where the eye information is coming in. Now you have the caudate nucleus, putamen, globus pallidus, externa, interna. All of these structures are causing these abnormal movements. Why does this happen? One simple explanation is what we call the direct and indirect pathway, that the information comes into the basal ganglia to be refined, to be clarified, so that the movements are precise when the actual movements happen. But then there is a direct pathway and an indirect pathway, and one is excitatory that causes the movement to happen, and one is inhibitory that puts brake on the pedal. And if the gas is too much or the brake is too much, then the movement becomes abnormal. So that's the old model. The newer model in explaining this is what we call the center surround model. That the basal ganglia job the movement proceed to be able, the base of the thumb has to be stabilized, the wrist has to be stabilized so that the thumb moves to do what it wants to do. So we can understand them a little more better. The main classic movement disorder, which is my main way as soon as the patient starts moving the hand. So as patient uses the hand to do the gestures, the tremors stop right here, and then the tremor comes back as the patient again relaxes the hand. So that's a classic resting tremor. Then the patient has other problems, like when they are asked to do like finger tapping and other things. They are more slow with the recycled, and you can increase the recycling by inhibiting the destruction, or you can give substances that look like dopamine to the brain without increasing dopamine, and you can give substances that block the destruction even peripherally in the blood to make more levodopa available to the brain. You can also give dopamine in many newer ways that are more constant release. So this is just a quick example of innovation. We have a dopamine infusion pump or levodopa infusion pump that can give levodopa continuously to the patient instead of pills that are given intermittently. Or you can even block the Parkinson's disease right in the brain by putting a wire in the brain and hooking it up with a pacemaker-like device, which is called deep brain stimulator or deep brain stimulation surgery, and really control the symptoms very well. Now, moving on to some other examples of abnormal movement disorders that I deal with that might be worth knowing, I will highlight another important one, which is not very common, but is really, really important to know because we created. This is called neuroleptic toxicity. Neuroleptic is any medication that reduces dopamine in the brain. So in some sense, it is basically blocking dopamine and causing Parkinson's theoretically, but can cause many other problem in addition to causing Parkinson. And I highlighted few different syndromes that are grouped under this kind of concept of dopamine blocking. So the main one is the neuroleptic malignant syndrome, which basically is an acute problem that happens when you suddenly block dopamine. Now, most of us normal people have a large reserve of dopamine, and we can lose 60% of our dopamine without having too much of a problem. But if someone like Parkinson's patient who has already lost 60-70% of their dopamine, if you now give them a neuroleptic, a dopamine blocker, now they have no reserve left, and they go into severe acute state of Parkinson's, which is called the neuroleptic malignant syndrome. There are other problems that can happen with dopamine blocker. You can have a syndrome of akathisia. I showed you one example earlier, which is an inner restlessness. You can create Parkinsonism. Luckily, it goes away once you stop the medication. You can create what is called tardive dyskinesia, which means Tardive means late onset, and dyskinesia means any abnormal movement. So these patients can develop tics, tremors, choreas, and other maybe dystonias and many problems which are late onset, meaning that you have been on dopamine blockers for a long time. But that's not the problem. The problem is that many of these patients, once they start having these problems, they will not go away even if you stop the medication. So these are permanent side effects, and which is a really bad problem, right? So because you can stop the medication and those side effects are still there, and so you better not cause them, rather than causing them permanently. There are other problems like serotonin syndrome and acute dystonic reactions that can happen with the medication. So medications that we use, which are brain eating medication that affect dopamine or serotonin, are very powerful medications. They can create a lot of movement disorders, and a lot of patients in my clinic are due to that. Another classic example of a movement disorder is what we call essential tremors. I showed you the tremor before. These are tremors that are present in the hand. Uh, Unlike resting tremor of Parkinson's, they are present when someone is trying to do something with their hand and it's shaking, or they can have a tremor in their head. They can have a tremor in their chin, and so on and so forth. And these runs in families. They can be treated with medication, but they cannot be cured. You can suppress them like hypertension and diabetes. You have to be on lifelong therapy once you get those. And just like hypertension and diabetes, over 10, 20 years of having them, they can have complications, especially if they're untreated. Dystonias, I mentioned those, abnormal muscle contraction. So here is an example of dystonia. You can see the platysma muscle in the neck dystonia of this patient with the head being pulled down. Here is another example from my clinical case where the head is just being pulled down and lower because of the dystonia of the muscle spasm of the neck muscles. Here is an example of a dystonia of the eyes. Patient is having trouble opening their eyes, get triggered by light, and does, even without triggers. And another example of dystonia of the jaw. Patient is having trouble closing their jaw. And they can be dystonia of jaw closure, where they have trouble opening the jaw. There could be dystonia of the foot, with the foot turning in, very common in Parkinson's patient. And here's one very, very important tip to remember: an isolated head tremor, when the head is kind of shaking like that, or jerky like that, or side to side, is a neck dystonia until proven otherwise. So people usually think of a head tremor with an essential tremor. Yes, essential tremor patients commonly have head tremor, but an isolated head tremor without any hand tremor is cervical dystonia until proven otherwise. Here are some couple of video example of these dystonia. So is a patient with blepharospasm, with trouble opening her eyes,
Medical
excessive
record number
blinking,
is
very small eyes. She cannot keep it open.
2496625.
And there is also some
Today
facial
is
dystonia with pulling
September
of the face
11th,
on the side.
2004.
And then here is
Miss
another
O, can you
example of a
just look into the
dystonia with
camera for
eyes
me?
and neck involvement. So patient now has this
Look,
jerky head
let
tremor
me
side
just,
to side with
let me
movements of the head,
look at your,
along with the eye closure or
yeah,
blepharospasm,
try to turn your
as
head to
another
one side
example
and then the other
of
for me.
dystonia, very disabling. And you can notice the lights are closed because patient has severe eye
Okay, now
spasm
to the
with
other
the
side.
light in the room. How do you treat these dystonias? There are many different medications available to treat them, but the highlight is chemodenervation or Botox. The first line treatment of cervical dystonia is Botox. It can be really effective. So this patient on the right side of the screen, you can see, has a very bad cervical dystonia with the head almost down, and with botulinum toxin injections or Botox injection, the head posture is significantly improved. And we do like 100 patients of Botox every month in our clinic. Very effective. Tics is another disorder that is pretty common as a movement disorder. There are various different syndromes of tic, but the highlight of the syndrome is the Tourette syndrome. Tourette syndrome is someone who has tics as a kid, starting before age 15, and the tics keep on going for more than 1 year. They often run in family. The tics can be many different things. So tics can be sniffing, can be throat clearing, can be neck kind of a tick, and tick can be pulling head back, tick can be cracking your knuckles. So tick can be many different types, or tying, twitching of the shoulder. Tick is just an abnormal movement that is always the same, so you can really think of it as a signature of the patient. You can, you know it's him by their tick, and it's very precise. The fluctuates come and go. Sometimes they're worse with anxiety. They can be held back only partially, and then the tick does come back, if they keep holding it for too long, and so on and so forth. Another thing I mentioned was chorea, abnormal movement, fluctuation, twitching, jerking, unpredictable kind of a movement. There are many syndromes that can cause chorea. Of course, the classic one is Huntington's disease. That was the patient that I showed you earlier. It's an autosomal dominant disorder. So if you're born with the gene, then you will get it. It's a very classic example of disorders which are called trinucleotide repeat disorders, where there is three nucleotides on the gene that are repeated at the end of that gene for a certain numbers, and if those repeats become too much or too long, then that creates an abnormal protein and abnormal function. So the repeat in Huntington's disease is CAG repeat, CAGE or CAG repeat disorder. And this is seen on chromosome 4, normal length in less than 25, 24. And if you get more than 27 or 31, then it creates problem. The longer the repeats you have, the sooner the problems start in the child. So someone who has a repeat of 100 may have problems at 3 4 years of age, and someone who has repeat length of 35 may have problems in their 60s or 70s years of age. The classic hallmark of Huntington's disease is a loss of caudate and basal ganglia, including thalamus. So what happens is that the lateral ventricles, which is a normal control patient here, are typically a triangle like. They become more like a boxcar shaped or a squarish kind of a ventricles, and that is because of the atrophy of this related to the Huntington's disease. So this was a very brief and quick and fast overview of movement disorders. I went through many of these things too fast. You can pause the video on some of the slides and watch the details. And you can and I'll share you with you in a minute here some more resources where you can find more about movement disorders and neurology. But first, let's do a fast quick picture quiz. So if you're watching the video recording, pause the video on each of these slides and try to remember what information was it. So on these pictures, so here's picture number 1. What is the abnormality? What is this area of picture, and what disease it is related with? Pause the video here and try to write the answers and go back to the video and find it, or search on the internet, Dr. Google. Here's picture number 2. What are these cells? What is the abnormality here, and what disease it is related with? Here's picture number 3. How do you treat Parkinson's disease? We'll skip picture number 4 because I skipped that from my presentation. And here's picture number 5. Isolated head tremor is what? Diagnosis until proven otherwise. And what is the first line treatment for this disorder? And here's the picture number 5. What is the abnormal pathology shown here? What disease it is associated with, and what structure is causing this abnormal pathology? Very good. Thank you, everyone. So here's my email address to reach out to me. There are many resources that I would like to share with you to learn more about movement disorders and neurology. I run online courses. You can go to elearning.unmc.edu, elearning.unmc.edu, to find courses including neurological examination course and other neurology courses. We have channel of Apna Merit on YouTube, where we have a lot of educational programs for all of medicine. I also have a YouTube channel of my own where I publish information and video related to movement disorders. So if you Google my name, Danish Bhatti, on YouTube, or YouTube it, search it, you will find my channel. You can subscribe and like it, and you can follow. There's already more than 100 videos over there related to movement disorders, including lectures on movement disorders like cervical dystonia, Botox videos, and neurological examinations, so on and so forth, that you can find. And then lastly, I also run online course for movement disorders, mini fellowship, and we're building courses on Parkinson's disease online. And you can email me, or you can go to University of Nebraska Medical Center website, search for neurological sciences department, and you can find a lot of these courses information available over there. If you're not able to find them, then you can write me an email. Otherwise, type them, Google them, go to the website, search them, and you will find them. Thank you so much, and I'll stop right here.